Thank you to the organizer of this symposium for inviting me to speak. And I'm sorry I couldn't be there with you in person. I would much prefer to be in New York right now, but couldn't make it. And honestly, Dr. Liu's talk, I probably should have gone first, and the enthusiasm I have for seeing that kind of work is hard to describe. The goal of my talk is actually to convince those of you who are studying male LUTs and even female LUTs to do what Dr. Liu did. Hopefully by the end of my talk kind of have helped motivate some other ways of investigating how interventions like exercise, as well as other interventions that slow aging, could be relevant to the lower urinary tract of both males and females. I'm at the VA in San Francisco, also on faculty at UCSF, and please do reach out to me if you have questions or are interested in discussing this further. I don't have any relevant disclosures to this talk. I always talk with my research mission briefly. It's to help older adults with lower urinary tract symptoms, or LUTs as I'll refer to for the rest of this talk, by studying how aging mechanisms contribute to these common urologic symptoms. Today, I'm going to compare the epidemiologic evidence for the contribution of aging versus obstructive mechanisms to male LUTs as a bit of a compare-contrast and motivating factor. And then I'm going to actually give some background about how targeting aging kind of came to be in the aging research world and why that might be relevant to folks in the room. And really culminating with what's called the geroscience hypothesis, or framework for thinking about how to target cellular and molecular mechanisms of aging in order to prevent age-related diseases such as LUTs. And then I'll very briefly at the end discuss how I've started to target, or where my research is heading. I actually won't present much of my results because I have done that in other Caribou symposiums, and really wanted to focus on the overarching motivation for this work to try to increase the number of talks like Dr. Liu's. So most of you are familiar with this, but older age is associated with a greater LUTs incidence. So if you don't have LUTs, you're more likely to develop it, as well as progression. If you have it, it's more likely to get worse the older you are. And this is from the health professional follow-up study, but it has been replicated across many different cohorts across the world. What is also known, and has been known since the 90s, is that benign prostatic hyperplasia, or BPH, as well as bladder outlet obstruction, also increase with age. And this is kind of piecing together a few different seminal studies from the 90s, but you can see that with increasing age on autopsy studies, that the presence of BPH nodules increases as people get older. By the time they're in their 80s, almost every single man has evidence of microscopic BPH. What also increases is that your peak urinary flow rate goes down. So a low urinary flow rate is a surrogate marker of bladder outlet obstruction. It's used very commonly in urologic offices. And the prevalence of a low peak urinary flow rate, defined as less than 15 milliliters per second, increases with increasing age. What also increases with increasing age is prostate volume. And as men age, their prostate in general gets larger. And lastly, as men get older, the prevalence of LUTs, defined by the gold standard AUASI symptom index, a score of 7 or greater, indicates at least moderate severity symptoms. And that also increases with age. And the fact that all these lines are heading in the same direction has led to really a lot of seminal work over the last 3 decades, many different pharmaceutical as well as surgical therapies for obstructive causes of LUTs. But I'm going to try to test a couple of your assumptions. So I don't have a way to do a poll, but if you guys can pull out a pen and paper, I would love, or if you can remember, I want you to answer this question in your head and hopefully write it down to keep yourself honest. So what percent, given what I just showed you, what percent of severe LUTs, so an AUA score of greater than 20, which is the highest category, an indication for surgical treatment for BPH in older men, is caused by bladder outlet obstruction? give you guys a second to write that down or think through it. Okay, so I'm going to use this paper, which I've shown you before, but I've actually reworked some of the data to make it, I think, in a little bit more approachable format. So this is a JAMA rational clinical exam. It's one of my favorite papers. It is a meta-analysis of studies that did both urodynamics and administered AUA symptom index scores to men, and then tried to figure out how good is the AUASI at identifying men with bladder outlet obstruction, and also how many men with bladder outlet obstruction have LUTs. And the main point, they found 3 studies that did this, included 442 patients. The mean age of those patients in each of the 3 studies was somewhere between 65 and 68, so all older men. The prevalence of bladder outlet obstruction, not surprisingly, given the age range, was 68%, perfectly lining up with that graph I showed you earlier. And the paper used this data to report on the sensitivity and specificity of a LUTS questionnaire for bladder outlet obstruction, which is very reasonable and is obviously very clinically relevant. But what's cool is that with those 3 numbers, prevalence, sensitivity, and specificity, you can actually back calculate a 2x2 table, which is what I did. And for those of you who aren't familiar with 2x2 tables, they're used often to figure out both those statistics, sensitivity, specificity, and a bunch of other ways of thinking about how likely is someone to have something if they have an exposure or a risk factor or a positive test result. And so I took those 442 patients and doing some algebra, which I hadn't done in a while, figured out how many of them had bladder outlet obstruction and not. So those are the 2 columns, positive BOO and negative BOO. And then I also figured out how many of them had severe LUTs based on the AUASI score of 20 or greater or less than 20, and put them into those boxes. And then the reason I was really interested and excited about this is that there is a very commonly used statistics. This is going to get a little bit mathy, but I just want to prove to you that I'm not making up these numbers. Something called the population attributable fraction, which is the percent of diseased caused by a specific exposure or risk factor in the study population. And that's the standard equation for calculating it. And you'll notice the wording is pretty similar to what I had asked you earlier. And so using the numbers in this 2x2 table, I calculated the population attributable fraction of severe LUTs due to bladder outlet obstruction. So what is the PAF, otherwise known as the percent of severe LUTs in older men caused by bladder outlet obstruction? When you use that 2x2 table, you get 22%. So corresponding to roughly 25%. What that means is that 75% of severe LUTs, the most severe category in older men, is caused by something not bladder outlet obstruction, men who do not have any bladder outlet obstruction on their urodynamics. Doesn't mean that efforts to target bladder obstruction are futile, but what it means is that there's so much room to improve our treatment of severe LUTs in older men by thinking about the other 3/4 of patients. Now, you might say, well, but if they have bladder outlet obstruction, then certainly the LUTs is due to bladder outlet obstruction. So you can use 2x2 tables to answer that question as well. So one other way of rephrasing this and using this, the 3 studies published in JAMA meta-analysis, what percent of severe LUTs in older men who have bladder outlet obstruction, you look, they come to you, they have severe LUTs, you do urodynamics, they have bladder outlet obstruction. What percent of the severe LUTs in those men is actually caused by bladder outlet obstruction? I'm going to let you write that down again. %, under 50%, over 50%. Okay. So the answer is 30%. So, and I didn't want to show you more math equations, but, and I'm happy to show folks afterwards, but just think clinically about the implication of that, which is that someone comes into the office, with really severe symptoms. They're miserable. They really want you to help them. You do tests to look for the most perceived common cause of symptoms, and you find that it's there. You find that they have obstruction. Your treatment is actually still, even though you found evidence of what you thought might be there, only 30% of those men actually have symptoms caused by the thing that you think that they have. And that, you can imagine, a very long line of cascading effects of those assumptions in terms of how patients receive care, the treatments they receive, what we do if they fail treatment, whether you escalate or actually retest in your mind, oh, maybe it's not bladder outlet obstruction, or maybe it's something else. And so I won't kind of belabor that point. I think I've talked about it in a bunch of different ways, but this is a new way of thinking about why it's so important to think of mechanisms of LUTS that are outside of or complementary to bladder outlet obstruction. What's another mechanism? Well, why do people get LUTS as they get older? Why do men have more LUTS? Some of it is due to increasing bladder outlet obstruction, but a lot of it is not, and we don't know why. And that really motivates me. So what happens when you get older? Well, there are a large number of diseases that increase in prevalence as we get older. And this is a study, international study published in The Lancet about a decade ago. But you can see that the number of chronic diseases that someone has increases as they get older. It may be obvious, but you can see that there are almost no 20-year-olds who have 8 diseases, but there's, or 6 diseases, but there's about a third of 80-year-olds have over 3 diseases, and there are almost no 80-year-olds who have no chronic disorders. This also is irrespective of socioeconomic status, although socioeconomic status does contribute to the burden of both risk factors that cause age-related diseases, as well as their ability to be treated and diagnosed. But it does not matter from a international standpoint. This is a problem that affects both developing countries as well as highly economically advantaged countries. And we see this when you look at the world as a whole as well. As countries become wealthier, the number of years that their population lives with disability or multiple diseases increases. So despite having more and more money, people are living with many different age-related diseases, and LUTS is one of them. This also is seen as we have increased the life expectancy of different countries. What we're actually often adding is number of years lived with chronic disease, multiple chronic diseases and disability. We're not delaying the onset of these age-related diseases. We're just adding to the number of years that you survive with them. And that's also seen when you look across countries based on their life expectancy and years lived with disease. So all of this has led to a really renewed interest at the NIA and really across the country among aging researchers that we've ignored this major risk factor for so long. And maybe that's why we've made so little progress on these age-related diseases. So this slide is directly taken from Dr. Luigi Ferrucci, who runs the Baltimore Longitudinal Study of Aging at the NIA intramural program. And what he shows really nicely in the slide, I couldn't have replicated it myself, is that all of these age-related diseases are increasing in likelihood as we age. And that if you, and I'm not sure if you can see my pointer, it looks like you can, and that the onset of the first disease is kind of the end of your disease-free life expectancy. At that point, you will have at least 1 disease, but most likely in a few years, you're going to have 2 and then 3 and then 4. And what's also important to know is that if you prevented osteoarthritis at this point, not too long later, you're going to develop a different age-related disease. And if we keep playing whack-a-mole with age-related diseases, one, the patient's going to be taking 20 medicines, which I have patients who are taking 15 and 10, and they're miserable because of it, because you are trying to address these diseases one at a time and way beyond the point at which the pathology started. When someone has a greater than expected disease-free life expectancy, these are people who age more slowly. They still develop all the same diseases, but they develop them much later in their life. And so they have a lot longer period of life without disease. But the same concepts apply, that once they do develop a disease of aging, they are likely to develop another one soon after that. And again, if you were to prevent the osteoarthritis here, they were going to develop chronic heart or coronary artery disease a year later. And so you really actually, by attacking one disease at a time, you aren't going to make meaningful differences in disease-free life expectancy. And then lastly, we know that there are people who have accelerated aging, develop these age-related diseases at a younger age. And that might be due to genetic, environmental exposures, health-related behaviors, and lifestyle choices. The same concept applies, but these are the folks who are really would benefit from risk factor modification and targeting whatever is causing all of these age-related diseases to increase in simultaneously. What this ends in is multimorbidity, frailty, and disability. And I don't have time to kind of go into those concepts. They're each distinct, but that is the end consequence of when you have multiple age-related diseases all culminating and accumulating in the same individual. The last thing to kind of really hit home this idea of why biological aging is relevant to these age-related diseases is that, and again, this is a published slide from Dr. Frucci, when we're young, and this is people with average rate of aging, we have the maximum amount of biological aging, phenotypic aging, and functional aging. They are all fully compensated and fully resilient. As people age, though, the thing that first happens is that they start to develop biological aging, molecular and cellular changes that are occurring, but yet are being compensated and therefore are not yet manifesting at the phenotypic and functional level. You may not see tissue changes, or you may not see changes in blood pressure or biomarkers, circulating markers, but it is happening at a cellular molecular level. And that's the first time point at which you can detect it. At a certain point, though, you experience additional biological aging, and you are no longer able to compensate phenotypically. So you exhibit phenotypic decompensation, and yet you're still moving around your community fine. Your strength is still okay. Your cognition is still okay. You're still able to live. But if you looked at your tissues, you would actually start to see signs that they are not working as well as they used to when they were fully compensated. And then eventually you get to this point of frailty, multimorbidity, disability, where the biological age has progressed so far that it has had such profound effects on phenotypic aging that you are also exhibiting functional impairments as well. That's when people have symptoms. That's when people, you test them and you can see abnormal clinical tests. But what's important here is that there is a long period where if you went looking, you could find people who do not yet have functional impairments, but are experiencing accelerated aging. And potentially, if you targeted these folks, you could maybe prolong the period of time that they don't have functional aging, which is the symptoms that the patients care about and that we really should be targeting. That's the LUTs instead of the pathology behind the LUTs. So the NIA, as well as many others, have kind of rallied around this idea that biological aging is the underpinning that leads to different things that change with age at a phenotypic level and a functional level, and that is what all of those things contribute to age-related multimorbidity, the increase in these various age-related diseases. I think that LUTS is another age-related condition that we really need to think of similarly to multimorbidity. And what excites me about that isn't that it's just something for me to test epidemiologically, which I have done over the last 5 years. And we now are kind of running out of phenotypic aging phenotypes to show that they're related to LUTS. They all are. Similarly, functional aging phenotype markers are strongly related to LUTS, whether you look at it longitudinally, cross-sectionally in various different populations, women and men. So I think we'll continue to solidify that epidemiologic evidence, but what excites me more is actually we now have ways of measuring biological aging in large prospective cohort studies and clinical trials. And what I really want to know is whether or not those mechanisms are contributing to age-related LUTS. And the reason that that holds so much potential, remember those 75% of older men with severe LUTS that are not caused by bladder outlet obstruction. Perhaps by targeting biological aging, we may be able to move the needle for them. And that is what the field of science, of geroscience postulates, is that by targeting biological aging, that you can prevent multiple age-related diseases. So the idea of preventing osteoarthritis and cancer with the same treatment used to be considered crazy. But now understanding that arthritis and cancer actually may share biological mechanisms, it seems maybe a little bit more realistic. And if you throw LUTS into the mix, we've definitely shown that LUTS is acting like one of these other age-related diseases. And there are geroscience interventions that are being tested in humans right now. So this slide kind of shows the same thing as the other one, which is that we used to target specific diseases. Then we worked on prevention, but really the new age of aging research and even clinical care is geroscience, which is actually targeting these upstream effects of aging. And the ones that have been tested in clinical trials of humans are 2 different lifestyle ones, caloric restriction and exercise. And then a bunch of repurposed medications actually have shown to have important effects on some of these biological mechanisms of aging. You just saw Dr. Liu's talk on building preclinical evidence for exercise effects on the prostate specifically and bladder outlet obstruction specifically, which I think is incredibly important. And I'm so happy that there was all these questions about, well, what about all the other effects of exercise and how does that affect LUTS in an aging mouse? I think that those are critical questions to answer in addition to the work in the prostate. Also exciting, we just received a notice of funding from the NIDDK to test an exercise intervention in older men with LUTS due to suspected BPH. And we will be similarly now in humans seeing how these how an exercise intervention, a mix of aerobic and resistance, affects many of these different phenotypes as well. And so if you're interested in testing some hypotheses or thinking of measures that we should include in that trial, please do reach out to me.
Scott, we have to finish up now. Okay, it's time.
Okay, this is a 30-second slide, which is that this is a third of the list of the different frailty interventions in preclinical studies with mice. You should take a look at this if you're interested in developing preclinical models to test. And then my opportunity award is to really dive into mitochondria specifically using various different forms of human data as just one specific mechanism of biological mechanism of aging to attempt targeting one that is very intertwined with all of the others. A lot of people to thank, specifically Dr. Huang and Dr. Vanden Eden, who got me involved in Caribou by admitting me to their K-12 program. Several really critical Caribou collaborators, Dr. Ricky Strand, Lou, and Dr. Franco, and my funders,